Care of the Patients with Eye and Vision Problems, Chapter 47. The first disorder that we're going to talk about today are cataracts. And cataracts affect the lens. So you can see this yellow mark here, the lens here on the eye. It sits behind the iris, and the purpose of the lens is to focus images onto the retina. So usually it's clear, so images can be focused pretty clearly. In cataracts, the lens becomes opaque or cloudy. It can turn kind of yellowish brown, and then that light that's passing through becomes distorted. The most common cause is aging. So usually, as we get older, the lens loses water, it becomes more dense. Additionally, if the patient's had a lot of exposure to UV light, to sun, that can increase the risk of developing it earlier. But especially in our adults over 70, this is the most common. It can also, though, be caused by toxic causes, so corticosteroid use like prednisone for long periods of time, phenothiazine derivatives like thorazine can lead to toxic causes. There's also something called associated cataracts, which is just caused by things like diabetes mellitus, hypoparathyroidism, Down syndrome, sunlight exposure, and then there are complicated causes, including retinitis pigmentosa, which is this rare genetic disorder that breaks down the cells in the retina. But also glaucoma and retinal detachment, which we'll talk about a bit later. Cataracts usually happen in both eyes, but oftentimes we see it more acutely in one eye versus the other. So the symptoms, things that we would expect to find, is a decreased visual acuity. So changes in their prescription, reduction in night vision. They might have blurry or cloudy vision, decrease in color perception or color distortion. They could see double vision, and this is a painless loss of vision. So it's progressive and it's painless. When we are looking at the eye, if we use the ophthalmoscope, we can see this well, even without an ophthalmoscope. So take a look at the lower right-hand picture. You can see the lens is kind of cloudy, right? That's this opacity that is a characteristic of cataracts. The patient also has an absent red reflex. So when you take somebody's picture, sometimes we see red eye. With cataracts, the patient doesn't have red eye. Instead, it kind of looks almost like that bluish white color. We can also do the brightness acuity test. So a lot of times people with cataracts, or any other time there's like a media opacity, when there's bright light conditions, they're disabled because there's this intraocular scatter. So the BAT is used to test glare disability in these different bright light conditions. And we'd expect in cataracts that the vision gets worse under these bright light conditions, including, direct overhead sunlight, partially cloudy day, or bright overhead commercial lighting. So think about if you are shopping at the mall or something, there's that brighter light. So the only treatment really is surgery. That is the only way to treat cataracts, is to surgically remove the lens. And so what they do is they make a little incision, and the lens is either removed in one piece or in several pieces after being broken up using sound waves. They do keep the posterior capsule, and then they can replace it with this intraocular lens. They can insert it there. They can also, at this time, correct vision, right? So maybe somebody has cataracts, but it's also kind of like if they have other vision problems, they can be corrected at the same time. They can create a lens that can do that. After surgery, we want to be careful, right? We want to make sure that the patient is preventing an increase in intraocular pressure for a period of time. So things like bending over, right? Straining, that type of thing. We want to have them prevent infection, so good hand hygiene, have them administer their ophthalmic meds, provide any pain relief, and then, wear sunglasses, right? Especially when they're outside in brightly lit areas. So this slide just gives you an idea of what it's like to see with cataracts. So the picture on the left here is how normal vision would appear if you were just looking at this scene of the street. So it's unfortunately kind of a terrible picture, But you can see that things are much clearer with normal vision on the left, and then on the right, this is how it looks with cataracts. So you can see, just the field of vision is distorted, colors are distorted, but it is painless. So remember that too. It's progressive, it's painless, but this is kind of what we end up with. The nurse is teaching a client who must instill multiple types of eye drops before cataract surgery. Which client statement requires further teaching? Okay, the answer here is C. Multiple eye drops that are prescribed prior to cataract surgery must be taken on a specific schedule. They should not be mixed together for convenience of administration. The second eye disorder we're going to talk about is glaucoma. And I didn't mention this earlier, but one way that I would recommend studying these different eye disorders is to make a chart so that you can compare and contrast the different eye disorders. There are some similarities between them, but there are some pretty distinct differences too, and so having that chart to compare side by side has been very helpful for students. So when we're talking about glaucoma, we're talking about pressure. We'll talk about the different types of glaucoma here in a minute. But glaucoma right now, there's not a known way to prevent it. The best prevention against the damage, though, because the eyes there is intraocular pressure already. Usually it's between 22 and 32 millimeters of mercury. The best prevention against the damage that pressure from glaucoma can cause is for adults to have eye exams with glaucoma checks every 2 to 4 years before they're 40, and every 1 to 3 years before ages 40 and 54, and every 1 to 2 years between the ages of 55 and 64, and then after the age of 65, between every 6 to 12 months, right? So just based on that information that I just gave you, you can imagine that aging is probably, it's pretty common in the older adult, right? That checks are so frequent. But let's talk about the different types. So the most common type of glaucoma is primary open angle glaucoma. Sometimes it's just POAG, you'll see it. And what happens in POAG, we'll just call it POAG, is that the outflow of aqueous humor, which is the fluid inside the eye, that fluid through the chamber angle is reduced. And because the fluid can't get out of the eye at the same rate that it's being produced, it's always being produced, but usually it's being drained at a similar rate. When it can't leave the eye at the same rate it's being produced, intraocular pressure slowly increases. Now this usually affects both eyes. There aren't any early signs and symptoms because it happens slowly. So there's a gradual loss of visual fields that oftentimes patients don't really know because at first their central vision's not affected. That comes later. Sometimes they might have foggy vision. They might complain of eye aches or headaches, right? Think about all that pressure building up in the eye. Later on, signs and symptoms might be present, but by that time, there's already been this irreversible damage to the function of the optic nerve. Sometimes when people look at lights, they can see a little halo around the lights. And when they wear glasses, that decreased visual sensory perception doesn't improve. The second type is primary angle closure glaucoma, or PACG, or it's also called acute glaucoma. And acute would tell us what? That it's sudden. It's an emergency. So symptoms of acute angle closure glaucoma include a sudden severe pain around the eye that just kind of radiates. It spreads all over the face. So they might feel it in their eyebrow. They might have just a headache all over, feel nauseous. They might even vomit. They can see these colored halos around lights, and sudden blurred vision with decreased light perception. The sclera, which is the white part of your eye, can look red, and if you look at the cornea, it might look kind of foggy. And this happens because there's this forward displacement of the iris, and that presses against the cornea, it closes that chamber angle, and it suddenly prevents the outflow of aqueous humor. Right, so the pressure increases here. It's between or greater than 30. And earlier I had mentioned normal intraocular pressure as being 22 to 32. That is not, I want to take that back. 22 to 32 is that primary open angle glaucoma. When we're talking normal intraocular pressure, it's between 10 and 21. So pressure is higher in the primary angle open glaucoma, and then higher still in primary angle closure glaucoma. All right, so let's just look at this again with pictures, okay? So here we have the eye. We can see that, oh, let me pull up my laser pointer here. Okay, so this is the healthy eye, right? We can see it's hollow. In order for it to work properly, the gel in the posterior segment, and posterior is back here, right? The vitreous humor is the fluid back here, and that helps to keep that round shape. We also have fluid in the anterior segment, right, or the front part of the eye, and that is our aqueous humor. So they're present in these set amounts that apply pressure inside the eye to help keep its ball shape. In adults, the volume of the vitreous humor, or the fluid back here, doesn't ever change. That just stays the same. But the aqueous humor is continuously made from blood plasma by the ciliary bodies that are located just behind the iris. You can't see them in this picture because it's so, well, for one, it's kind of blurry. But this is just to give you a bigger picture anyway. So anyway, the fluid flows through the pupil into the bulging area here just in front of the iris, as you can see. So through the pupil, which is the little black dot in the center of our eye, and then out here. And then it usually leaves then as under the cornea, and then it gets returned to the blood. So we usually have about 1 ml of aqueous humor, but again, continuously made and reabsorbed. So about 5 mL a day. A normal intraocular pressure requires this balance between the production and the outflow. That makes sense. We need it to be equal so that we don't end up with too much, because if intraocular pressure becomes too high, the extra pressure compresses the retinal blood vessels and photoreceptors and their synapsing nerve fibers, which results in poorly oxygenated photoreceptors and nerve fibers, which can then become ischemic and die. When too many have died, then vision is lost permanently. Okay, so just very simple recap. There's an angle here, right, in the corner of the eye, where the iris and the cornea meet, where fluid drainage usually occurs. And when it can't happen, pressure increases in the eye, pushes on the optic nerve inside the eye, and leads to vision loss. Okay, and remember, normal intraocular pressure is between 10 and 21 millimeters of mercury. The primary open angle glaucoma, intraocular pressure between 22 and 32 millimeters of mercury, and primary angle closure glaucoma is an intraocular pressure greater than 30 millimeters of mercury. So there are a few different ways that we can test and measure for glaucoma. One thing we can do is a visual fields test. We can also do something called tonometry, which just measures the intraocular pressure. And there's a bunch of different ways that we can do this. Usually it's done by the optometrist, but we expect IOP is elevated with glaucoma, especially with that angle closure. We can, when we're doing visual field testing, it just helps us to determine the degree of peripheral vision, and it can be performed either with a computerized machine or with a confrontation test for rapid test. So perimetry is the computerized test, and it is preferred for measuring glaucoma. So during this test, they have the patient look straight ahead into a little viewer, and then they can push a little button when they see the moving light enter their peripheral vision. And so this can actually map out the peripheral vision and any deficits that they might have. If we were doing the confrontation test, so this is one where you sit in front of the patient and you ask them to look right into your eyes while you're looking into theirs. You cover your right eye and have the patient cover his or her left eye so that you both have the same visual field. Then you can move your finger or an object from a non-visible area into the patient's line of vision. And the patient that has normal peripheral vision should notice the object at about the same time that you do. And you can repeat this by then covering your left eye, having the patient cover their left eye, and then test for the right eye. You would then document any areas where you can see, but the patient can't. So obviously the perimetry of the computerized version is going to be more accurate, right? Gonioscopy is performed during the eye exam, and it helps just to evaluate the internal drainage system of the eye, which is also referred to as the anterior chamber angle. And remember, that angle is just where the cornea and the iris meet, where the aqueous humor drains out into the venous system. So just to look at the drainage. All right, there are some different medications that we can use to treat or to help to treat glaucoma. Remember that the medications that are used, they don't improve vision that has been lost, but they can prevent more damage by decreasing intraocular pressure. So that's the goal of all these meds, is to decrease intraocular pressure. And we have, just before we talk about the drugs specifically, they reduce intraocular pressure by reducing the production of the aqueous humor. They can increase the absorption of aqueous humor, or they can constrict the pupil so that the ciliary muscle is contracted, which helps to circulate the aqueous humor better to the site of the absorption. So we have our prostaglandin antagonist drugs, which reduce IOP by dilating those blood vessels in the trabecular mesh, which can collect and drain the aqueous humor at a quicker rate. We have our androgenic agonists and beta blockers, right, that reduce IOP by limiting the production of aqueous humor. They dilate the pupil, which helps to improve flow of fluid to its absorption site. We have our cholinergic agonists, which help to reduce IOP by limiting the production of aqueous humor and making more room between the iris and the lens, which helps with the fluid being able to drain. And then we have our carbonic anhydrase inhibitors, which directly and strongly inhibit the production of the aqueous humor. So this doesn't affect the flow at all or the absorption of the aqueous humor. Just some considerations, right? So if we're giving like timolol, right, a beta blocker, they're usually our first line drug therapy for glaucoma. Remember, though, that a lot of these meds can be absorbed systemically, and beta blockers can cause bronchial constriction and hypoglycemia, so we want to be really, really careful in patients who have asthma, who have COPD, who have diabetes, because it can also potentiate systemic effects from oral beta blockers. So if patients are taking orally beta blockers, it can cause bradycardia and hypotension, so we want to be really, really careful with those as well. The priority nursing intervention really here is teaching, okay? So what education would you prescribe to a patient that you have that's taking eye drops? So we want to teach them that the benefit of drug therapy really only happens when they're using the meds the way that they're prescribed. So usually it's every 12 hours. It's really important that they take their meds on time and that they're not skipping doses of their eye drops, because then they can develop higher intraocular pressure and they risk permanent damage, right, to their vision. We also, if they're going to be taking more than one eye drop, they should wait between 5 and 10 minutes between the drops so that one drug doesn't wash out the others or dilute the other. Another really important thing to teach them is good hand washing. So wash their hands really well before they're touching their eye. They should wash their hands before they're taking the cap off of the container. They should keep the eye drop tip clean. They should never, right, touch the tip to any part of their eye. And then there's also something called punctal occlusion. And that is just where, so after they instill, right after they instill the eye drop, they should put pressure on the corner of their eye near their nose. And that just helps to prevent systemic absorption of the drugs. So there are all these different eye drops that we can use. So surgery, we use it for open angle glaucoma when the drugs aren't effective at controlling the pressure. There's a couple different procedures that can be done. One is called a laser trabeculoplasty, and then there is also a trabeculectomy. The trabeculoplasty burns that trabecular meshwork, which scars it and causes the fibers to get tighter. And when those fibers tighten up, it increases the size of the space between the fibers so that aqueous humor can flow out. And when we have a reduction in that aqueous humor, when it's able to leave the eye, then it reduces pressure, right? Trabeculotomy is a surgical procedure that creates a new channel for fluid outflow. So both of these are just ambulatory surgery. They can also implant a shunt, a small little tube or filament that they connect to a flat plate. They put it on the outside of the eye, in the eye orbit. You can't see it, though. If you were looking at the patient, you wouldn't be able to see this plate. But the open part of that tube is placed into that front chamber of the eye, and then it drains through or around the tube into the area around the plate where it can collect and then reabsorb into the bloodstream. So just another option, but of course there are complications like choroidal hemorrhage, choroidal detachment, so things that we don't want in our patients. Also, if they're going to be having these surgeries, we want to make sure that we're still stressing the importance of adhering to a med schedule to keep pressure down. That they should wear sunglasses while they're outside. They should watch for signs of infection like yellow or green drainage. Avoid activities that increase intraocular pressure, things like bending over at the waist, sneezing, coughing, straining, restrictive clothing, right? So if they have a really tight shirt collar, and sexual intercourse. They shouldn't lay down on the operative side, and they should report severe pain or nausea, which could tell us that they have a hemorrhage. They should also report changes like if their eyelid starts to swell up, if they suddenly have a decrease in their vision, if they have bleeding or discharge, or if they're seeing these like flashes of light or floating shapes. So all these things are really, really important to report and to watch for. They should also note too that their best vision is going to take some time. After surgery, it can take like up to 6 weeks. So, they need to just kind of be patient and let everything heal. Blindness is a potential consequence of untreated glaucoma. So really, really, we talked about this a couple slides ago, but the best way to prevent glaucoma is to do those eye exams as recommended. So here you can see kind of what somebody with glaucoma might be experiencing. And this is most likely primary open-angle glaucoma. So you can see early on there's this loss of peripheral vision. And again, in primary open-angle glaucoma, this happens gradually. And it can lead to central vision loss. So you can see over to the right how that's kind of zoning in, but central vision can be lost with glaucoma as well. With this primary open angle, we'd also see a decrease in accommodation, maybe some halos around light, which isn't really clear in this picture. The patient might be experiencing, again, mild aches in the eye or head. Remember to differentiate between primary angle closure glaucoma, which happens faster, right? They have decreased blurred vision, colored halo around light, their pupils are non-reactive to light, then they have more severe pain, nausea, photophobia, or sensitivity to light as well. Macular degeneration is the deterioration of the macula, or the area of central vision. And it can be related to aging. It's very common during aging. Or it can also be exudative or related to fluids. There's 2 types of age-related macular degeneration. The first is dry, and this is the most common type. It's caused by this gradual blockage of the retinal capillaries that allow the retinal cells, they're not getting very good perfusion, and so they become ischemic, necrotic. Central vision declines. Sometimes the patient describes kind of mild blurring or distortion at first, and then eventually all central vision is lost. This is painless and happens gradually. There is also something called wet age-related macular degeneration, and this happens because there's a growth of new blood vessels in the macula, and these new blood vessels have really thin walls, and they can leak blood and fluid. This is why it's called wet. Exudative macular degeneration is also a type of wet macular degeneration, but it can happen at any age, so it's not related to aging. The condition can occur in only one eye or in both eyes, and know too that a patient that has dry age-related macular degeneration can also develop exudative macular degeneration. So they're not, it's not one or the other necessarily. Patients that have exudative degeneration have a sudden decrease in vision after there's this detachment of pigment epithelium in the macula. The newly formed blood vessels invade the injured area and they cause fluid and blood to collect under the macula, kind of like a blister, that leads to scar formation and then this visual distortion. So management of patients with exudative or wet AMD is geared towards slowing the process and identifying further changes in visual perception. Fluid and blood sometimes can be reabsorbed in some patients. We can also do laser therapy to help to seal the leaking blood vessels, which can limit the extent of the damage. And then there are these different ocular injections with vascular endothelial growth factor inhibitors. So we want to prevent this new vascularization to prevent the leaking. That can improve vision, again, for patients with wet AMD. One of the easiest ways to screen for age-related macular degeneration is to use an Amsler grid. And an Amsler grid is a chart with these lines and a dot in the center. Your doctor can even give you one to use at home, or providers often do. So if patients have dry AMD, they should check their vision in each eye every day or as often as the doctor advises, and it really only takes a few seconds. So what they should do is cover one eye, then using the other eye, look at the first grid, and then repeat with the opposite eye covered. So the concerns and things that they should call their provider for is if they see lines like on the right that appear wavy or curved, if they see any blank or dark spots other than the center dot that's supposed to be in the middle of the grid, they should call their provider. And then if the lines around the center are wavy and distorted. So again, the one on the right is how it would appear to somebody with macular degeneration, and on the left is what somebody with normal vision would see. So here you can see, again, a comparison between what somebody with normal vision would see on the left compared to macular degeneration on the right, where you can see that central vision is affected. The nurse is caring for 4 clients. Which is the highest risk for development of macular degeneration? Go ahead and put me on pause, make your selection, and then hit play to hear what the answer is. Okay, so remember, anytime you're looking at a comparison between different clients, we want to count the number of risk factors that are present. So most of the time you're given options where maybe multiple clients have risk factors, so our job is to choose the one that has the highest risk factor. So the answer here is D, the 57-year-old, 60 inches tall with hypertension. Remember that dry AMD is more common and progresses at a faster rate among smokers than non-smokers. That other risk factors are things like hypertension, female gender, short stature, having a family history, and a long-term diet that's poor in carotene and vitamin D. So client D here is short, has hypertension, which both increases risk for AMD. A retinal detachment is the separation of the retina from the epithelium. Detachments are classified by the type and the cause of their development. So one really common cause of retinal holes, tears, and detachments is a posterior vitreous detachment, or PVD it's called. This happens normally with aging, so as we get older, the vitreous gel often shrinks or gets thicker, and remember, the vitreous gel is the gel in the posterior portion of the eye, and when that happens, it kind of pulls away from the retina, which is in the back of the eye. So the patient might experience these small flashes of light. They might describe them as like shooting stars or seeing these lightning streaks, like we can see in the upper right-hand corner. It happens in one eye, and it's more visible in a dark environment. They might see with these flashes some floaters, and I'll show you that on the next slide here. So in addition to aging, risk factors are things like extreme myopia, inflammation that's happening inside the eye, and a cataract or having laser eye surgery. When the PVD does not cause a retinal tear or detachment, then no treatment is needed. So again, Aging, extreme myopia, inflammation inside the eye, cataracts, or laser eye surgery are all risk factors. The client needs to see the doctor immediately. This is a medical. They have to go in so that they don't lose their vision permanently. What they do for treatment is something called scleral buckling, and this is performed with the client under general anesthesia. But the eye care practitioner can repair wrinkles or folds in the retina and indents in the eye surface to help to relieve some of that tugging, that pressure that's being placed on the retina. The indentation that they make, or they call buckling, is performed by placing these tiny pieces of silicone against the outside of the sclera, or the white part of the eye, and then they hold it in place with this band that goes around it, and that helps to keep the retina in contact with the choroid for reattachment. And then while they're doing that, they can drain any fluid under the retina. They can also place this gas or silicone oil inside the eye to help to promote retinal reattachment. And what happens is that this little kind of bubble floats up and against the retina, and it holds it in place until healing occurs. Now, they have to be really careful, and there's some post-operative care that they need to adhere to. So they have to wear an eye patch usually, or a shield right after surgery. And we want to make sure that we as the nurse are monitoring the vital signs and checking that patch for drainage. If they've had that little bubble placed in their eye, they have to keep their head in the position that the surgeon prescribes to make sure that reattachment can happen. So maybe they have to lie in a particular position at night, which can be really uncomfortable for patients and hard for them to get used to. They should also avoid any activities that increase intraocular pressure, and if you need reminders of what that is, you can go ahead and look at table 47.2 in your book. Tell the patient to avoid reading, writing, and doing work that's really up close, like sewing in the first week after surgery, because they can cause the eyes to move really fast, and then detachment can occur. They also need to really watch for signs and symptoms of infection, right? So what are signs and symptoms of infection? Well, things like drainage that's like green or yellow, if the patient develops a fever over 101, if they have sudden pain, all those things. Detachment, signs of detachment are things like reduced visual acuity, eye pain, a pupil that doesn't show accommodation, so it does not constrict this is talking about reaction to light, so a pupil that's not constricting in response to light. And then they should really make sure that they're letting their provider know if any of those things occur. Here's an example of what somebody with a retinal detachment might see. So notice the loss of side vision, the bursts of spots or floaters. Note too that the vision itself isn't blurry. Would the patient experience pain? No, they would not. And does this affect both eyes? No, it just happens in one eye. The nurse is caring for a client who reports slow onset of a gradual loss of vision in the center of both eyes. The client describes the vision as foggy and reports concerns of ongoing headaches from trying to concentrate to see. What condition does the nurse anticipate? Put me on pause, make your selection, and then hit play. All right, so the answer is B, primary open-angle glaucoma, which is the most common form of primary glaucoma, might not have any symptoms in the early stages. In later stages, though, the client experiences a gradual loss of central vision field, and vision can be described as foggy. The client may have mild eye aches, experience headaches, and then late signs and symptoms include halos around the lights, loss of peripheral vision, and a decreased visual sensory perception that does not improve with eyeglasses. A client is being discharged after surgery to correct a retinal detachment. Which symptoms will the nurse teach the client to immediately report to the eye care provider? This is a select all that apply, so select the applicable answers and then hit play and hear if you're right. All right, purulent drainage in the affected eye, yes, so A is correct. It can be a sign of infection. B, a fever of 102 Fahrenheit, also can be a sign of infection, so B is also correct. C, a pupil that constricts in response to light. So this is one that we do expect, right? So not something that the patient would need to report. And D, improved visual acuity. All right, also something that we can expect. Those are favorable findings, right? And then finally E, pain in the eye. This is something that they would want to report as well. So the answer is A, B, and E. Moving on to Chapter 48, Assessment and Care of Patients with Ear and Hearing Problems. Take a moment to match the different hearing assessment tools on the left with how they work on the right. So put me on pause and do that, and then we'll go over the answers. All right, so number 1. A voice test for hearing is conducted by asking the patient to cover one external ear canal, so just put their hand over their ear, and then you stand a foot or two behind them, quietly whisper a statement, and then you ask the client to repeat it. You do that each ear separately. If they don't respond correctly, you can try a louder whisper. If you suspect that the patient is lip reading, you can use your hands to kind of block the view of their mouth, or you can stand behind them while you're doing the whispering. So this is a pretty simple basic test that you can do as the RN. It's also, there's more complex hearing tests that audiologists, physicians, APRNs, specialty nurses, physician's assistants can do to help to determine the type and extent of hearing loss. Voice tests are really very, very basic and kind of elementary. Audioscopy. So that test involves the use of a handheld device to generate tones of varying intensities to test hearing. Auditory sensory perception can be measured at a 40 decibel intensity at frequencies of 500, 1,000, 2,000, and 4,000 cycles per second. Tuning fork tests are test hearing, and they include the Weber and the Rene tests. And these tests are useful, although they're limited in distinguishing the difference between conductive and sensorineural hearing loss. We'll talk more about those types of hearing loss in future slides. But we use tuning forks with frequency ranges that are kind of corresponding with the normal speech, so the tune of normal speech. The Weber tuning fork test is performed by placing a vibrating tuning fork. So you strike the tuning fork, and then you put it in the middle of the patient's head, and you ask them to indicate what ear they hear the sound louder. A normal test result is that they can hear it equally in both ears. The term lateralization is used if in one ear the sound is louder than in the other. So for example, we'd say lateralization to the right if they can hear the sound louder in the right ear. Sound will be louder in the affected ear if it's conductive hearing loss, but it'll be louder in the good ear if it's sensorineural hearing loss. The Rene tuning fork test compares hearing by air conduction with hearing by bone conduction. So we're comparing air conduction versus bone. Normal hearing is indicated when air conduction is 2 or 3 times as long as the bone conduction time. So to do this test, you place the vibrating tuning fork stem on the mastoid process, which measures bone conduction, and you ask the patient to let you know when they can't hear the sound anymore. So maybe you have them raise a hand or a finger. When they can't hear the sound anymore, then you bring the tuning fork around quickly in front of the outer ear to measure air conduction. You want to make sure that you're not touching the patient, and then you have them raise their hand again, or however you decide to have them indicate when they can't hear that any longer. So we would expect that they'd continue to hear that sound 2 or 3 times longer once it's been moved out in front of the ear after not hearing it when it's been touching the mastoid process. Auditory dysfunction and hearing loss. So because hearing loss might be gradual and it might only affect some aspects of hearing, a lot of adults just aren't really aware that their hearing is impaired. In the U.S., it's estimated that about 15% of the adult population between 20 and 69 years old is affected by hearing loss, and then the number grows as we're talking about people in their 70s and 80s. But with special care to the ears, we can preserve hearing at maximum levels. So what are some modifiable risks for hearing loss? This is things like using ear protection if you're around loud sounds, not listening to music really loud, and then having simple hearing tests done annually. We want to address any barriers to the use of hearing protection. So sometimes it's just not available. Sometimes it's expensive. There are these over-the-ear headsets or foam ear inserts when people are exposed to it's exposure to persistent loud noises. So it's not like you hear a loud sound once, although sometimes if it's very loud, hearing can be damaged. We also want to suggest patients use earplugs when they're swimming to help to prevent ear infections. And then there's over-the-counter products called like Swim Ear that can help to dry the ear after swimming. We also want to teach the client to keep clean. So what does that mean? So using things like bobby pins or Q-tips or toothpicks to clean the ear canal can be dangerous. They can actually scrape the skin off the ear canal, and they can also push the cerumen into the eardrum. They could puncture the eardrum. And if cerumen buildup is a problem, then we can teach the patient the proper techniques to remove it. So to do that, you can look on chart 48-2 in your book, and that gives you some good education tools for your patients. There are 3 types of hearing loss, and we're going to talk about them more specifically. Conductive hearing loss, sensorineural hearing loss, and then mixed hearing loss, which is just a combination of the 2. Conductive hearing loss results from the obstruction of sound wave transmission that's caused by any type of inflammation or obstruction of the external or middle ear. Things that can change the eardrum, like if there's a bulging, a retraction, or a perforation, can damage the middle ear and can lead to conductive hearing loss. Things like tumors, scar tissue, otosclerosis, which is this overgrowth of soft bony tissue on the ossicles that occurs when patients have had middle ear surgery in the past, can also lead to conductive hearing loss. Because that sound is being blocked, it affects all pitches and frequencies. Interestingly, though, patients actually hear better in loud, crowded environments. So when we look at the Weber test, that's the one, remember, where the tuning fork goes on the top of the head. In patients with conductive hearing loss, we expect that the sound is going to be what? So it's going to be louder in their affected ear. Sensorineural hearing loss happens when the inner ear auditory nerve, cranial nerve number 8, is damaged. This can happen for a few different reasons. It can happen just by age. It can happen as the result of prolonged exposure to loud noise, or just a one-time exposure to a really loud noise. But it damages the hair cells of the cochlea. There's a lot of medications too. More than 200 meds and chemicals are ototoxic to the inner ear structures, and their effects on hearing can be either transient or permanent. They can be related to the dose, and it can affect one or both ears. So think about like gentamicin, loop diuretics like furosemide. We talked about pushing furosemide and how if you push furosemide too quickly, it can lead to ototoxicity. Also different like platinum-based chemotherapy agents like cisplatin, for example, all can be ototoxic. It's especially dangerous in patients that have reduced kidney function because increased ototoxicity can occur because drug elimination is slower, especially among our older patients. So what happens here, our patients have a harder time hearing in large, crowded environments, especially understanding speech. So they can hear, but they can't make out what the person is saying. And that can be super frustrating for people. As we get older, there are ear and hearing changes that happen. So with that are these nursing adaptations, implications for care when we're talking about older patients who maybe have some of these changes. Some of them are harmless and some can threaten their ability to hear. So we always want to screen older adults for hearing acuity. Just starting by asking, do you have hearing problems? Or has any family or friends expressed concern about your ability to hear? Sometimes families notice behaviors, like the person maybe is saying like what a lot, or they're kind of tilting their head and straining to hear what's being said. So we always want to do these assessments. So some of the different ear or hearing changes, I'm going to let actually you read through this slide and just understand what the changes and then what the implications are. Remember, one important thing is not all older adults have hearing loss, so please don't assume that. And some things that we want to do, right, is make sure that we have, when we're doing these assessments, that the environment's quiet, that there's not these distractions, that you're facing the patient, right? We never want to overemphasize. There's kind of this fine balance, right, between trying to help a patient understand when we're talking about somebody with hearing loss versus like being over exaggerative and going over the top. So treatment. Early detection is really important. We want to figure out what's causing the problem so that we can help to prevent and stop further hearing loss. There's different drug therapy that can be done as well, and drug therapy is really meant to treat the underlying problem. It might help to prevent further loss. They can give, for example, antibiotics if somebody has otitis media or other ear infections. If there's localized edema, we can reduce that, both of which help to improve hearing. We can give pain analgesics. We can give antiemetics for vertigo, dizziness, nausea, vomiting. Antihistamines, right? If you're really people that suffer from allergies, seasonal allergies, for example, have a harder time hearing when they're congested and stuffed up. There's benzodiazepines too that can help to relieve some of the vertigo and dizziness. There's different assistive devices as well. We can use these in patients that have permanent hearing loss, right? So those aren't for transient hearing loss. This is for permanent hearing loss. There's portable amplifiers that can be used. So if the patient's watching TV, they don't have to like crank the volume. If you've ever been into somebody's home who has hearing loss and they're watching TV, sometimes they have the volume on at an incredible rate or volume. And it is disturbing to others, right, that maybe don't have hearing loss. They can also get amplifiers for their phone to help to increase the volume. It allows the caller then to speak in a normal voice, because if you've ever called somebody with hearing loss, sometimes you have to shout, and that can be really challenging. Some phones too have a video display, so they'll type out the words that are being spoken by the caller, so they can read that instead of having to try to hear. There are also things like flashing lights. So maybe if the doorbell or the phone rings, then a light flashes to help to alert the patient visually. They have those too with smoke detectors for safety. Some patients might have a service dog to let them know if somebody's talking to them, if there's danger. Again, just to say, hey, your phone's ringing or doorbells are ringing. There's different agencies out there that can assist with hearing impaired people. So make sure that you're connecting your patients with those resources. There are also these small little portable audio amplifiers that can help with communication with hearing in people with hearing loss who don't use a hearing aid. You can also have your patient use a stethoscope. So you can speak into it. Don't speak loudly. They wear the stethoscope and you talk into the diaphragm and then they can hear you. There's also a hearing aid, right? A small little electronic amplifier. You can see the different types here at the bottom of this slide to help patients with conductive hearing loss. They're less effective for sensorial neural hearing loss, right? Because that has more to do with the nerves and not the conduction of sound. There's a bunch of different sizes, placements. See, some go in the ear, behind the ear. Some are minis, you can't even see them. A bunch of different sizes. The most common hearing aids are pretty small though. They even have some that attach to your glasses. And those, obviously other people can see better. The cost though varies quite a bit depending on the size and the quality. Some people too need extra education about the best use and care for their hearing aids. And just remind them too that the hearing aids don't produce the same type of hearing that normal hearing gives you. So they might want to start using their hearing aids really slow, just kind of wearing them at home and only part of the day at first. if they're like listening to the TV or the radio and reading aloud, can help them to get used to the new sounds because it's going to feel and sound different. The other thing is not only does it amplify just people talking, but background noise is amplified quite a bit as well. So patients really need to concentrate and learn to filter out those noises. They can be really disturbing at first. There is a chart on 48.9 in your textbook that teaches patients how to care for their hearing aids. They're super delicate, right? They're really expensive and they're delicate, so they really, people need to know how to handle them and care for them. They also tend to get lost in healthcare settings easily. So, maybe the patient takes them out at night and they drop on the floor or something, patient gets discharged, patient gets transferred, they get lost easily. And if, when they come in, you document all their belongings, right? If when they come in, we document they have hearing aid and they don't when they leave the healthcare facility, guess who is on the hook for that? Right, so we want to make very sure that patients that come in with hearing aids leave with their hearing aids. Not only because of cost, but also then, the patient can't hear if they've lost that hearing aid. And they are very, very expensive to replace. Okay, there's some different surgical managements that can be done as well, right? The tympanoplasty is a reconstruction of the middle ear to help improve conductive hearing loss. They can be really simple. And it can be really complex. They can use a bunch of different materials to make these repairs. They can use skin grafts, muscle fascia, venous tissue. If the ossicles or the little bones in the ear are damaged, then they might have to do more extensive surgery to either repair or replace them. And they can go in either through the ear canal or by an incision behind the ear. A stapedectomy is a stapes operation, and that can be performed to improve hearing in patients who have, they call it a frozen or a stuck stapes bone. And this usually happens in patients who have otosclerosis, but there's some other hereditary conditions that can also lead to this, or if patients have had really, really serious middle ear infections or surgeries on their middle ear, this can happen too. Remember that the stapes is the last hearing bone in that chain of bones in your middle ear. And it's usually mobile, so it moves around. It's attached by a little ligament to an opening of the bone that houses the inner ear, called the oval window. And a frozen stapes bone can cause mechanical or that conductive hearing loss because the airwaves are not able to get through. The third type is a cochlear implant, and this can help patients that have sensorineural hearing loss. It's a superficial surgical procedure that implants this device. The procedure doesn't actually go into the inner ear, so it's not really considered a surgical correction for hearing impairment, but they do have to place this device surgically. And basically what it is a tiny little computer, and it helps to convert sound waves into electrical impulses. So they put these little electrodes near the internal ear, with the computer attached to the external ear, and then the electronic impulses can directly stimulate the nerve fibers to help the patient to hear. Otitis media is just another name for ear infection. The common forms of otitis media are acute otitis media, chronic otitis media, and serous otitis media. Each type affects the middle ear, but they have different causes and different pathologic changes. If otitis progresses or is untreated, then permanent conductive hearing loss might occur. So acute and chronic are similar. There's some kind of infecting agent that's in the middle ear, causes inflammation of the mucosa. It leads to swelling, irritation of the little ossicles or the bones within the middle ear. It's followed by this purulent inflammatory exudate, so this pus basically. Acute just has sudden onset and lasts 3 weeks or less. Chronic is it happens after repeated acute episodes. It has a longer duration, and it causes greater middle ear injury. It might be the result of continuing presence of this biofilm in the middle of the ear. And remember, a biofilm is a community of bacteria that kind of gang up against whatever the host's defense mechanisms are in order to continue to survive and grow. So therapy for complications associated with chronic otitis media usually involves some kind of surgery. The eustachian tube and mastoid, which are connected to the middle ear by a sheet of cells, are also affected by the infection. And if that eardrum membrane perforates, the infection can get thicker, and then the eardrum can actually get a scar in it if it's not treated. Also, it can lead to necrosis of the ossicles, which destroys middle ear structures and causes hearing loss. So, like, we sometimes think of ear infections as like mild things that are pretty normal, but they can get really bad. So we do want to keep an eye on them. If a patient has pain after they've gone through antibiotic therapy, and if when we look in their ear, the eardrum's still like bulging out, like you can see in the picture here, then sometimes they have to do a laryngotomy, which is just a surgical opening of the eardrum, and that just helps to drain the middle ear fluid, and it's like this immediate relief of pain, right? So think about if you've got all this pressure, and then there's this immediate relief with the removal of that fluid. They just go in. It's a really small surgical incision. It's often done just in an office or a clinic visit, and it heals really quick. Another thing, the way that they can get the fluid out is with a needle. So they can just aspirate with a needle. If there is serous otitis media, and for patients that have repeated episodes of otitis media, there's a small grommet or a polyethylene tube can be surgically replaced. So you've heard of people that get tubes in their ear. They surgically input the tubes in to help with continuous fluid drainage. And that's kind of the purpose of that. So there's some patient education post-op, which you can see here. And these are important things to teach. They include things that increase pressure in the ear, like flying, straining with bowel movement, and excessive coughing. We want to teach them to avoid water. Avoid bending over, avoid rapidly moving your head, bouncing, bending. We want to avoid infection, so good hand hygiene. At the first sign of excruciating pain, so a little mild pain is expected right away, but if they have all of a sudden this excruciating pain that is concerning, we want them to go see their provider right away. And then, as always, complete your entire course of antibiotics. Meniere's disease is something that happens. It's a degenerative condition that can lead to progressive hearing loss in 20 to 50-year-olds. It happens because there is this excess of endolymphatic fluid that distorts the entire inner canal system, and it decreases hearing by dilating the cochlear duct, which causes vertigo due to damage to the vestibular system. So this is a super, super, super uncomfortable medication for patients. Signs and symptoms include headache, increasing tinnitus or ringing in the ear, feelings of fullness in the affected ear. This can all precede an attack of vertigo. So patients often say that the tinnitus is this like kind of low-pitched roar or humming sound, which gets worse just before and during an attack. A lot of times hearing loss occurs with the low frequency tones, but it can progress to include all tones, and with repeated attacks, hearing loss can become permanent. When patients have vertigo, sometimes they have these like really whirling sensations where they can't stand. It can cause them to fall over. And sometimes even when they're lying down, they feel like they're going to fall. So they might like grab onto the side of the bed or put their hands on the ground to brace themselves to keep from falling, even though they're already laying down. And these periods can last for 3 to 4 hours. Even though after the attack, the patient still doesn't always feel right? They still might feel dizzy. It can happen, nausea and vomiting can develop, rapid eye movement, severe headaches. So it's super, super, super unpleasant, right? You can see in the picture here, so there's a TV show called Arrested Development, and there they portray a character called Lucille 2, who has extreme vertigo. And the show portrays it almost as funny. They make a joke out of it. However, as you can see and as you can imagine, it is super uncomfortable. So it's really not very funny. Treatment. Okay, so there's some things that we can do. There's some different medications. One thing that we would give would be diuretics. That seems strange, right? Diuretics for a hearing problem. But remember, there's this excess of endolymphatic fluid. So diuretics decrease endolymph volume, which can help to reduce that pressure. We can also give antihistamines, antiemetics to help to decrease the severity and symptoms of an attack. We can give gentamicin or corticosteroids as well to help to reduce some of those symptoms. We want to encourage a low salt diet. Again, that reduces endolymph fluid. If our patients smoke, we want to tell them to stop smoking. It constricts blood vessels, which can increase the problem. Same with caffeine. And then surgical procedures include labyrinthectomy. And remember, the labyrinth is the bony outer wall of the inner ear and the temporal bone. And so what they do in a labyrinthectomy is resection that vestibular nerve, or they completely take out the labyrinth. They should know, though, that when that's done, there is total hearing loss on that operative side. So it's really not something, I mean, it's severe, right? So the symptoms and signs are so severe that this is the treatment that we go with. The other thing that we can do is pressure pulse treatment, where they send these little micropulses into the ear to help to displace the fluids. The nurse is caring for a client who's experienced an increased frequency in Meniere's disease attacks. When the client asks, "Will I have to have surgery?" what is the appropriate nursing response? Select all that apply. So select your answers, put me on pause, and then when you're ready to hear them, hit play. All right, so the correct answers here are C and E. So C, you sound like you're concerned about surgery, and E, different types of surgery can be considered with your healthcare provider. So allowing the client to express fear, as C, the answer in C is therapeutic. The healthcare provider and the client can talk about different types of surgery if this seems to be the best option after considering the risks and benefits. So that would be E. Because remember, risks of surgery, the labyrinthectomy is permanent hearing loss, right, on that affected side. The other statements are inaccurate or not therapeutic. I'm going to start this by playing you some audio of what tinnitus can sound like. So you can hear that there's really a wide range in one or both ears, wide range. It's this continuous ringing or noise perception that happens in the ear. Sometimes when it's mild, it can go unnoticed during the day, but again, can also be so loud that it interferes with thinking and attention span. Imagine trying to focus if you had those noises or that noise in your head. Some patients report that constant ringing makes them feel like they're going mad or that they're kind of losing their mind. There are some different contributing factors: age, sclerosis of the ossicles, Meniere's disease, as we just talked about, and then different medications like aspirin and NSAIDs, high-ceiling diuretics, aminoglycosides, antibiotics, exposure to loud noises, and other inner ear problems. There's some different diagnostic tests. Let me start over. Diagnostic tests there's not a tool that we can use to diagnose tinnitus, right? Because it's kind of a subjective, it's like pain. We can't objectively measure it. However, we do tests to perform hearing and ruling out other disorders. There is something called a tinnitus and hearing survey that can be used to help patients and clinicians determine whether intervention for tinnitus is warranted, is necessary. So some different interventions. And really, the problem and the management of tinnitus vary based on underlying causes. When we can't figure out what the cause is, or the disorder is untreatable, then our therapies kind of focus on ways to mask the tinnitus with background sounds, with noisemakers. Maybe they use music during sleeping hours. There's ear mold hearing aids that can help to amplify sounds to drown out tinnitus during the day. And a method that's helpful to some patients is pramipexole or Mirapex, which is an anti-Parkinson drug. And you can also refer patients to the American Tinnitus Association. It helps patients learn to cope. There are other local and online support groups as well that are available out there to help with this potentially debilitating disease. Last question here. The nurse is caring for a client with tinnitus. Which client statement requires nursing teaching? So when you have a question like this that says requires nursing teaching, that should tell us that we're looking for an incorrect answer, right? So go ahead and put me on pause, make your choice, and then hit play. All right, so the incorrect answer here is C. I take aspirin every day to help reduce my risk for having a stroke. Or I should say that statement is incorrect. Man, I think the ringing on the last slide has affected my ability to think. Anyhow, so yes, C is the correct answer for this question because it's an incorrect statement by the client. Taking aspirin every day to reduce risk of having a stroke can actually increase the risk for tinnitus, right? Remember, NSAIDs, high-ceiling diuretics, aminoglycoside antibiotics, all can increase tinnitus symptoms. The other statements are appropriate and they don't require any type of nursing teaching.